Hi, I'm Dr. Mariam George, and I'm going to give you a brief overview of caring for the dying person. Why is it so important to talk about death and dying? Each of us have a story in our lives which at some stage comes to an end, and that's when we die. It's really important for us to hope for a good ending, and hence the need to look at how we can make this happen. After all, death is an inevitable, unavoidable part of life in itself. So let me start by sharing Bob's story with you. Bob is an 85-year-old gentleman who has a diagnosis of dementia and COPD. This is his 8th hospital admission. He has had all the active interventions possible, which unfortunately are not making a big difference. He's got a very supportive son and daughter who are really keen that their father doesn't suffer. They are also worried because we've had a conversation about whether it's appropriate to continue with treatment, whether it's appropriate to continue with intravenous fluids. He's sleeping most of the time, taking occasional sips now and again, but he's starting to cough when he tries to drink, suggesting that his swallow is no longer safe. So, from a multidisciplinary assessment, it's been recognized that Bob is likely to be in the last days of his life. In 2014, the Leadership Alliance for the Care of the Dying People published a report which identified 5 key priorities to consider when we're caring for the dying. Once dying is recognized, it's really important to ensure that this is sensitively communicated with the patient where possible, if they're awake and alert and able to have the conversation, and with their significant loved ones or their significant others. Once they are informed of this, then the next step is to support them with decision making, taking into consideration what matters most to the person who is dying. And for that, we have to make sure that we involve the patient, again, as I said, where possible, and their loved ones, exploring what the preferences of the person dying might be. Once we establish what their preferences are, then the next stage is to ensure that there is an individualized care plan that looks into ensuring comfort and safety. And for this, we need to make sure that we look at their symptom management, we look at their spiritual needs, their psychosocial needs. And this care is then carried out in a coordinated manner with compassion. It's important to know what normal dying looks like. Dying is a normal biological process. One may find that the deterioration is gradual, and often with normal dying, that's the case. There's an increasing loss of energy. The person spends a lot of time sleeping, becomes less able to have conversations, generally withdraws from social interactions by large. They won't be able to eat and drink as they normally do. The inability to eat and drink is usually the indication that their bodily needs are coming down because they're not up and about as they normally do. They gradually will spend moments of being less conscious and aware, and over a period of time that becomes more and more prolonged to the point that they then stop waking up. Then one might notice that there are changes in their breathing. There might be pauses in between. There might be pauses that are getting longer with big breaths. By this stage, that's pretty much towards the last hours to days of life. If the patient's loved ones are not aware of what to expect, these changes can feel quite frightening, which is why it's important to help people understand what to expect when their loved one is dying. In the current state of how the world has evolved, most of us don't really get to experience death and dying as often as perhaps previous generations have done in the past. So, the other physical changes that may be observed in time is a gradual shutdown of circulation, particularly at the extremities. The hands may be cold. The nurses might actually touch the nose of the patient and say that, their noses are cold too, which again indicates that overall different functions of the body are closing down. At the last stages, there will be complete stopping of their breathing, and at the last point, their heart stops. The heart stopping when death happens is not quite the scenario when there's a cardiac arrest, where the heart stopped because of a problem that may be reversible. The heart stopping in dying is when every other system has stopped working and ultimately there's no longer a heartbeat. Which is why it's really important to talk about resuscitation not being the right treatment to offer at that stage. So, we've talked about normal dying. What happens in hospitals or in cases where patients might be poorly due to different reasons, maybe end-stage cancer, maybe end-stage organ failure? In some cases, it's harder to really pinpoint whether they're dying or not. And when they're in hospital, it's important that we look for, or when they're at home, we assess and look for causes that might be reversible. For example, an infection. They might be seriously ill with an infection. You bring them into hospital, you give them treatment, and they'll recover. When it gets to the point where, as with Bob, they brought him into hospital, they gave him treatment, but it's not really improved. On the contrary, it's not just that he's not responding to treatment, he's continuing to deteriorate. In that case, it's important to have a conversation with the team that's looking after him, because recognizing death is a multidisciplinary process. Very often, our nurses are the first to identify that a person is deteriorating and dying. It's really important to have a conversation with the team to establish what the overall impression is. Once that's recognized, then we need to weigh what kind of treatments and management plan will be most likely to help them. Priority at this stage is to ensure their safety and their comfort, and not to burden them with excessive interventions or investigations. It would no longer be appropriate to check blood pressure and temperature every 4 hours, because it will not change how you're going to manage them. In that stage, we ensure that the right plan is in place, as discussed earlier, having spoken to the family, having spoken to the patient if possible, and making sure that there is a clear understanding of what needs to be done to make sure this person has a very comfortable, peaceful end. We need to ensure that inappropriate interventions such as resuscitation or cardiopulmonary resuscitation is not considered, and that decision is then documented. We may need to be very clear about the escalation plan with regards to treatment. We may need to be quite explicit with stating that this person is no longer meant to have blood tests or intravenous antibiotics or artificial means of feeding, again, because none of that is really going to help. At that stage, we must make every effort to find out what would the person want. If they're able to speak for themselves, we may be able to explore whether they want to be in hospital till the end or whether they'd like to go home and be surrounded by their loved ones. We may be able to explore what kind of music they enjoy listening to. How do they want their last days to be? Are they worried about anything? Is there anything that they wish to avoid? Is there anybody they'd like to have with them? It's really positive when we're able to establish each individual's wishes and when we're able to fulfill them. One or two occasions that come to my mind is when there was a lady who had struggled to eat and drink because she had really awful nausea and she was vomiting whatever she was trying to take, and she hadn't been able to have a decent meal for ages. One of the therapy team happened to chat with her, and she talked about how it was so important for her to have been able to sit outside in her garden in the sunshine and have a slice of lemon drizzle cake. Ironically, just at that moment, we happened to have some lemon drizzle on the ward, and when the therapy team came and shared this with us, this was in a hospice, by the way, I said, well, why not we offer it to her? She may not be able to swallow it, but if she would like, she can at least taste it and enjoy that moment. The lady was absolutely thrilled, and we were able to carry that little wish out for her. The other occasion is more recently. We met a lovely 77-year-old man at home. He is increasingly bedbound, feeling quite tired, worrying about how he might die, how his family will cope. And I asked him, what would he like? Would he like a drink? And he said, oh, I'd love to have a tall glass of bitter. And I said, well, why not? He got so excited, he started rubbing his hands in glee and looked at his brother and said, please, can I have one today then? And it's those little things that often make a massive difference when time is short. So the key point is, if you don't ask, you don't know. And it's very rewarding when you spend that extra time to check with the patient where they can or with their loved ones. Coming back to Bob again, the relevance of involving and supporting family is huge, because we should always remember that when the person dies, the memories of what happened around the death of their loved one will stay forever in their minds. It also has an impact on their grieving process. People who've never experienced death before will have many anxieties, as I mentioned before, about what to expect, how they need to be themselves, whether they've done the right thing for their loved one. There has to be sensitive, open communication, helping them to understand every step of the way what we discussed earlier, what to expect with the dying process, that sometimes it might be gentle and uneventful, but rarely. There might be some slight difficulties on the way, but reassuring the family that we will do everything possible to ensure that if they do have any symptoms, if their loved one becomes agitated or restless, we will do what we can to manage that. We might need to use medications, injections, to control those symptoms. It's really important to do what you can to explore families' understanding of the person's wishes. Particularly in Bob's case, he has dementia, he's really poorly, he can't talk for himself. And in which case, it's often the son or the daughter that would know what dad really likes, or what music he enjoys, whether he'd like to have the radio playing in the background, because even if he might not be able to engage, he might still be able to hear. It's important to let family know that there is no perfect way that they need to be. Helping them understand that they are being supported will help. Helping them understand that they can just be normal around their loved one, having normal conversations as best as they can, may go a long way in helping them process what's going on. Sometimes we tell families that it's important to tell their loved one it's okay for you to go, because we have seen situations where people are agitated when they're dying because they're not ready to leave their loved ones behind. And sometimes they need to have permission, almost, their loved one, their family members saying, "It's okay, Dad, you can go, we'll be fine, we'll be all right." Sadly, in the current situation of the pandemic, the opportunities for loved ones to be around their family member who's dying is limited. In our trust at the moment, when a person is identified as being within the last days of life, we do allow visiting. But again, it's a very unnatural environment. They're having to come in prepared to wear the protective equipment, all those layers that stop just meaningful communication sometimes. In other situations, we have to make do with video calls. If there's a risk to the family member visiting, they might choose to not attend in person, but choose to do it over a video call. Whatever is possible to help them be part of that time, we must explore and facilitate. As I said at the beginning, it's really important to make sure that they are fully informed in a sensitive manner. Families are different. Some will be more demanding than others. And everybody reacts differently to stressful times. And the dying of a loved one is a very stressful time. We can never be kind enough to family members going through a hard time. What we have to ensure is that we are constantly providing them with reassurance that dignified, respectful care will be provided as best possible. If they state that they want to take their loved one home and look after them, we will do everything possible to make that happen. For some families, it's important that they've done that, even if there is a risk that the person may die during the transfer. Because the person who's dying may have told them explicitly, "I do not want to die in hospital." And therefore, for them, they need to know that they've done everything possible to make that happen. And they may find peace in the fact that even if the death happened on transfer, they have done their best to fulfill that wish. As medical professionals, we have to, of course, ensure that all this is very clearly communicated and those preferences have been established and we have informed them of all those risks, and there is a mutual agreement that those risks have been accepted and everybody is still happy to proceed. Once we've established what the patient's key wishes are, the next stage is to make sure that they have a comfortable last few days or weeks of life. So not everybody will experience all the key symptoms that we're going to talk about in a minute. Some people have a very uneventful dying process. However, in some cases, there might be situations, for instance, due to their underlying condition, that they may be at risk of some symptoms. And as healthcare professionals, it is our responsibility to make sure that we're prepared for any of those usual symptoms that we might anticipate. So the common symptoms that we would see or prepare for are pain, nausea, vomiting, breathlessness, restlessness or agitation, and in some cases, increased secretions. It's important that we help prepare the family for what these secretions might be. Because as the person becomes less conscious over time, they may not be aware of that chestiness that's very audible to those around them. The important thing is to help the family understand that normally for you and I, when we walk around, there's a lot of secretions in our throat that we are able to clear. However, when a person is dying, their ability to shift those secretions diminishes. And it's just a collection or pooling of the normal secretions that often becomes audible and loud at the last stages, particularly in association with the breathing. There might be some other symptoms to prepare for. For example, if a person has a cancer that's spread to their brain, they may be at risk of seizures. If they have a risk of bleeding, then there might be some external visible bleeding at the last stages. And in some cases, we might be wanting to be prepared for slightly more than the usual level of agitation. It's also important to make sure there's a clear plan for managing their mouth care, their bowel and their bladder care, and as they become more bedbound, looking out for their skin care as well. Even with the best level of care, some people will be at risk of developing sores in their pressure areas. The important bit is that that's checked regularly and addressed as best as possible. When we anticipate these problems, the way we manage it is by prescribing medications for each of those symptoms we just described. We need to ensure that suitable medicines are prescribed in the injectable form because we recognize the person will not be able to swallow medications orally towards the last days of their life. It's important that we review those medications on a regular basis. In some cases, they might not need a single injection or medication to be administered. Even then, it's important that we document that the medications have been reviewed and there is no change to the management. In some situations, they might need some intervention, either for pain or for breathlessness. And if they're needing more than the odd dose through the day, if they're needing 2 or more doses of a pain relief, for instance, then it's possible that they could benefit from having a continuous infusion of that medication in a syringe driver. So, there's clear guidance from NICE on how to ensure that anticipatory prescribing is done in a safe manner. We have to take into account the likelihood of specific symptoms occurring. As I mentioned earlier, are they at a risk of a specific symptom happening more than others? Have they already been on pain relief that they've needed for a long time, and therefore we have to make sure that's continuing in a different form? We need to consider the benefit and harms that they may have by administration of drugs. Have they had any specific drug sensitivities? So, for example, for pain control, we normally use morphine. But if a person has got significant renal impairment that's been recognized before they are dying, then you may choose to use fentanyl or fentanyl, which is a safer option for those in renal impairment. We also need to factor in how long it will take to obtain these medications if they're at home, and where can we ensure that these drugs are kept safely. It's really important to have an individualized approach for managing these cases or situations, because one size never fits all. Everybody dies in their own way. So we talked about the 5 common symptoms and what may be slightly different if they've got specific conditions. And we talked about potentially considering medication through alternative routes continuously, such as through a syringe driver. We talked about being mindful of other complicating factors such as organ failure, maybe kidney failure or liver failure, that would prompt us to think about the right medications to be used in the right way. We need to be mindful that if a person is dying at home and needing these medications, some of which are control drugs, we need to make sure these drugs are being kept in a safe place. There was a situation where I was looking after a lovely elderly lady who had 2 daughters, and she wanted to die at home. But one of the daughters came up to us and said, "I'm very happy to look after Mum at home, but I cannot have these drugs in my house because her grandchildren might have access to them," and she wasn't sure whether they could be trusted. So the plan was that the drugs would be kept in her sister's house, just a couple of doors down, and when the need arises, she would be available with the medication for mum at the time. So again, highlighting the need for us to be mindful of the circumstances where we would need to prescribe such medications. And as mentioned earlier, we would need to ensure that we know what the existing medication history is to factor in what would need to continue in the appropriate form. For example, we talked about pain relief, but another example is if somebody has been at risk of seizures and have already been on an anti-epileptic medication, then you would need to look at what drug can be administered ongoing in a syringe driver so that they do not miss out on having that anti-epileptic management. Just briefly about syringe drivers and continuous subcutaneous infusion. So it's a much less invasive alternative to intravenous administration of medication. It's a battery-operated pump which is sited with a needle that sits just under the skin subcutaneously. The important thing to be aware of is that continuous subcutaneous infusions by a syringe driver are used also in people who are having active treatment. So commencing somebody on a syringe driver does not automatically imply that they are dying. This is really important because there might be some families who may have misunderstood the use of the equipment. The other advantage of using a syringe driver is that we can administer up to 4 drugs as long as the volume can be accommodated within the syringe at the same time. It's very manageable at home, and we will reassure the family that there will be a nurse visiting every day to replenish the syringe driver and ensure that the medications are being delivered as expected. We would also explain that the doses in the infusion may be adjusted depending on the number of extra doses that have been needed over a 24-hour period. The only thing that might come as barriers to effective use of syringe drivers may be if the person who's dying has significant edema overall, or if they're at risk of bleeding because they've got low platelets. Usually, in most cases, nearly every dying person will tolerate a syringe driver. As I said, it's really important that we help the dying person's family or carers understand the purposes of all the interventions that you're putting in place, the medications that you're putting in place, what each medication is for, and how we will be monitoring their needs on a regular basis. It's really important that they don't have any misunderstandings. People may associate morphine with increasing the chances of death happening quicker. People might be anxious that some drugs might be making the person more agitated. It's really important to explore their anxieties around such situations. Ultimately, having an open, clear channel of communication makes a huge difference to the overall outcome. So, in summary, what I would like to stress is that care of the dying is everyone's responsibility, whether you're a healthcare professional or not. We've talked about the priorities of care, how to recognize dying, the need for sensitive communication with the patient and significant others and involving them as much as possible. We've talked about the need for having an individualized plan of care and how we would need to anticipate certain problems and put measures in place so that we're able to deal with those issues as they arise. I have included some resources which may be helpful for further reading. Thank you very much.